All right, good afternoon, everybody, and thank you so much for joining us this afternoon, reaching out all the way from Texas Southern University, and for everyone that is at the Addis Center in Precinct 2. Thank you for making time to join us today as we spend the next hour to discuss a very important topic on Huddle Up for Better Health, improving prostate cancer awareness and screening options.
Texas Southern University's Center for Biomedical and Minority Health Research Community Engagement Corps is funded by the National Institute of Minority Health and Health Disparity Research Center for Minority Institutions program. The CEC works directly with communities to identify and address health-related concerns and reduce health disparities related to ethnic minorities. We provide health education and partnerships with healthcare systems, federally qualified health centers, community and faith-based organizations. For more information, visit us on social media at CEC Texas Southern U or give us a call at 713-313-1233 or send us an email at cbmhrcommunity@tsu.edu.
Great, so that is really a brief introduction about who we are at the Community Engagement Corps NIH-funded grant here at Texas Southern University. And we want to say a big thank you to our hybrid location this afternoon, where we're actually having an outreach event. We have vendors, participants, volunteers, several of the Community Engagement Corps staff members, Dr. Loud, Ms. Evelyn Casas, Ms. Selena Bean, and so many other vendors are out there at the Precinct 2 at the Senior Center this afternoon as we are having this outreach on prostate cancer. And we want to say a big thank you to Ms. Asha Minix and Ms. Cherry Bowen, who has allowed us to use the Addis Senior Center for our hybrid event this afternoon. The Addis Community Center aims to provide an active, friendly, and comfortable environment for senior citizens to achieve their personal goals, belong to a group of friends, and enrich the quality of life of people. Community members can try something new at the center, like Tai Chi or line dancing. Community members can also connect with their creative side through ceramic and knitting classes. So a big thank you again to Addis Senior Center in Precinct 2 for collaborating with us on today's program. And we want to say a big thank you to another funded grant, which I have the opportunity to be the principal investigator on. This is funded by the Center for Medicare and Medicaid Services, the Aggressive Prostate Cancer Study here at Texas Southern University, where we are working in collaboration with the Cancer Center of Eastern Methodist Hospital to develop a predictive model on the incidence of aggressive prostate cancer among African American males. And we are also working in collaboration with Sankofa Research Institute to engage African American men and community partners to develop a social determinant of health-based interventions for aggressive prostate cancer among African American men. So if anyone is willing to hear more information or partner with us about this study, please feel free to reach out to us at TSU, and we'll be glad to share more information with you. And again, very big thank you to all of our vendors. Today's event would not have been successful without every vendor that we have listed on the screen, and even so many more people that are out there at the Addis Community Center this afternoon, Addis County Public Health, Cecil's TSU Breast Cancer Screening and Prevention Center, Hope Clinic, Avenue 360, Texan Veteran Commission, Canopy, MB Anderson, Amory Group, 100 Black Men, Alzheimer's Association, the Busy Wellness Center, Faith-Based and Community Engagement of the Texas Department for Family and Protective Services, East Harris County Empowerment Council, and Aetna Group, as well as the Council on Recovery. So I want to say a big thank you to all of our vendors, because each of you have made an incredible contribution to the success of today's program. And towards the end of today's program, we will be having survey. The link of the survey is going to be posted in the chat box for those that are joining us virtually. And for all the people that are in person at the Addis Center, The surveys would also be distributed. We really want to hear the feedback from community members about your take on what we've been able to share with you today and how you would want us to present more information in our seminars that we have monthly in the upcoming future. One of the good things is that we will be able to have a giveaway in form of a gift card for 10 attendees that are able to complete this survey this afternoon. So please complete the survey, and that will guide us as we continue to evolve in addressing the needs of the community. Welcome again, everybody, to our June seminar titled Huddle Up for Better Health, Improving Prostate Cancer Awareness and Screening Options. This afternoon, we have the privilege of having Dr. Rodney as our great speaker for today's session. Dr. Hunter is a clinical associate professor at TSU College of Pharmacy and Health Sciences here in Houston, Texas. He is a clinical pharmacy specialist in breast medical oncology at the University of Texas Health Memorial Hermann Cancer Center. He served as the program director for the TSU Breast Cancer Screening and Prevention Center, funded by Susan G. Komen. He is actively involved in the Center for Biomedical and Minority Research at TSU on research projects and community outreach initiatives. He is also a clinical assistant professor in the Division of Internal Medicine, Department of Oncology at the University of Texas Health McGovern Medical School in Houston, Texas. Dr. Hunter obtained his Doctor of Pharmacy degree here from Texas Southern University College of Pharmacy and Health Sciences in 2007, after which he completed an oncology fellowship at the University of Texas and the Anderson Cancer Center in Houston, Texas. So without further ado, I will turn it over to Dr. Hunter as he takes us further as we discuss prostate cancer among community members. Thank you so much, Dr. Hunter, for joining us. Over to you, sir.
Definitely my pleasure, and thanks for the invite. Let me get my screen shared so we go about some of this great information to hopefully help our individuals in the community reference to prostate cancer awareness and just information about prostate cancer in general. So we got there. All right, I think I got my screen here good there. So we're in a great place there. Once again, thank you for the introduction, Dr. Adjuole. I really appreciate having the opportunity to speak to the community about prostate cancer. Obviously, I work, the majority of my patients throughout my career have been breast cancer patients, but recently I have been able to start getting involved more with the health and the awareness reference to distribute information to prostate cancer, which is also something that, of course, I'm turning 40 this year, and you're going to see that 40 is a magic number when it comes to prostate cancer. It's something we certainly would want to, make sure we understand what we need to do, African-American men specifically, when it comes to your age and prostate cancer and your family history. So some objectives that I have today, I'll talk a little bit about the prostate gland itself, actually, a little bit about the anatomy and the function of what it actually does. I think a lot of people think about the prostate, or at least men I know, and don't actually understand what the prostate is or what's its job in the grand scheme of things. We'll also discuss like some of the pathology and the etiology and the prevalence of prostate cancer, which relates to pathology, relates to what are those cells really made of and what really causes men to develop prostate cancer regardless of their age. What are some risk factors that are associated with prostate cancer, and why do some men get prostate cancer more frequently and more often than other men? Also the prevalence. So how common is it? Like if I'm 35 years old, how high of a risk do I have of developing prostate cancer if I'm that age versus if I'm 65 years old, how high is the risk of developing prostate cancer? Also explaining, some of the different types of treatment that patients who actually get prostate cancer would possibly have to undergo. And then some lifestyle modifications that might help, because a lot of times I get from patients like, how can I prevent this from happening? How can this be something where can I get on top of it before it actually occurs? What are those types of things that I can do as a patient to help prevent myself from getting prostate cancer if I know I'm at higher risk? And finally, I'll talk about some sources of information that are great to either help a patient who has prostate cancer, or maybe more frequently or more commonly in the masses of who's listening today, the patients who are at high risk, like what can they do to help themselves in reference to preventing prostate cancer. So talking about the prostate gland itself, it is like a walnut-sized gland that's located right below the bladder. As you might imagine, if something is located below the bladder, when patients get prostate cancer, actually their bladder enlarges. So the prostate enlarges, pressing on their bladder. So you're going to notice that when I start talking about the symptoms and things that we need to worry about when we have the early symptoms associated with prostate cancer, a lot of those have to do with how a man urinates. The urethra actually surrounds the urethra. So as it gets bigger, what does it do? It presses on the urethra. Those tubes in the urethra are what are connected to your bladder. So your bladder, which holds all your urine, if that prostate gets bigger and bigger and it starts to press on the urethra, it then causes there to be unusual flow of urine throughout a patient's body. And that can be detrimental as far as symptoms are concerned, discomfort, even as serious as having infections down there because of this ununiform flow of urine out of the bladder because the urethra is being pressed upon. It also makes and stores semen. So there are sexual dysfunction problems associated with prostate cancer if not addressed, or depending on how it's treated, you also have some issues there if you're not getting the surgery that spares the nerves in that area, as the nerves are damaged, possibly through maybe a certain intervention. If not done in a certain way, then that's something that to talk about, and something that's associated with erectile dysfunction. So I always talk to patients about their sexual health as well in reference to prostate cancer and how the prostate gland is important. So if you are going to have to do things to treat the prostate cancer, how we're going to address it. And then the last thing is, like, when you think about the prostate gland and how it functions in reference to urine flow, it actually can slow or stop the flow of urine depending on the size of it. There are some other conditions that mimic prostate cancer. You shouldn't be alarmed if you have this condition versus having prostate cancer. So we'll talk about that towards. So an overview of prostate cancer, when you think about, there's thousands of men each year that actually are diagnosed with prostate cancer in the United States alone. It is something that, as these cells become normal in their growth, and we call it malignant. Malignant means it's something that's cancerous, that's invasive. That means it's growing further and outside of its natural habitat, and that causes us to get uncomfortable when we're thinking about ourselves as clinicians in the of oncology, because if it's growing outside of its natural habitat, definitely can give rise to spreading to other parts of the body, which can cause a patient even problems if they have cancer. Finally, when you look at the disease, it's a very slow progressing disease. It's one of those diseases where I've multiple patients that have actually had the symptoms of prostate cancer for 5 to 10 years before they actually come in, and they really are at the point where they're having very severe symptoms at this point, and then they finally will then go to treatment. And that's no knock on them, if you will, because if an individual is just having an irregular flow of urine, naturally there's going to be a million and one thing is associated with it outside of prostate cancer. So there's a lot of different reasons might have these abnormal flows of urine, and sometimes even going into your regular primary physician, you might describe these symptoms, and if you're not of normal age of developing prostate cancer, it may be something that's overlooked or treated. Then that's a prescription to help to relieve the symptoms. So certainly something that you as a patient, you always want to, you always want to make sure that you as a patient are advocate for yourself. So there'll be a lot of information I'll give you today to take it back yourself, and it can be something that protects you or protects a family member, because we'll talk about your brother, your father, your son. All of these are also that might benefit from this information, even if you are not actually the patient who has cancer, who's having the symptoms. And then finally, when you do see patients that come in actually having those rather severe symptoms of prostate, then it's actually progressed outside of the prostate. And that's where we need to get to. We don't want to get to a space to where a patient has prostate cancer, they're having back pain, or they're having all of these symptoms that are outside of the prostate means that maybe the disease is spread outside of its normal area, harder to treat for patients. So I'll make sure we kind of go over these in depth, these symptoms of prostate cancer, because these are really the things, you take away anything from the talk that we have today, these are important things to know. Is like, what are the symptoms of prostate cancer? You have that, you have your father, my father is, 61 years old, or 62 actually this year. So he's 62 years old. So you're going to see when I talk about the prevalence, he's at the prime age to develop prostate cancer. It's a much more common cancer at his age group versus me at 39. So want to make sure he's aware of those symptoms. I'm aware of those symptoms. My mother's aware of those symptoms. Everybody that's around the circle needs to make sure they're aware of the symptoms, because if these types of things change abnormally for long periods of time and they get progressively worse, then these are the types of things that can pick up prostate cancer early on before it gets to the point where it is outside of the prostate and much harder to treat. So the frequency in reference to urination. So a lot of times patients with prostate cancer, they'll have to urinate very frequently at night. That'll be the place when they really see that they're needing to urinate more frequently. They have a very hesitant urination, meaning there's not a steady flow of urine when they are urinating. It either comes out very slowly or it comes out abruptly and then stop. That's indicative of the prostate actually enlarging and pressing against the urethra. Also, you look at the discomfort in reference to burning or pain when a patient is urinating. This is also something that we commonly see with patients who have more advanced stages of prostate cancer. Also, trouble actually controlling their urine. So even a patient does not want to urinate, they don't have very good control of their urine because the bladder is being pressed upon. So they can actually urinate when they're not intending to. It can be directly related to the size of the prostate. Blood in the urine or the semen. So post-coitus or after sex, if there's blood in the semen or there's blood in the urine after urination, those are also things that can show that there's damage in that area, in that tissue, whether it's the urethra, whether it's the bladder, or it's the prostate that's causing this blood. Because as the prostate grows abnormally, that semen specifically comes out of the prostate, it can be tinged with blood, where there's a little bit of blood in it. So all of these things alarms to send you to your PCP's office first. You don't necessarily need to go to a urologist or a oncologist office immediately, but these symptoms, especially persistent, there needs to be a conversation with your PCP to possibly get that referral to your urologist if needed. Painful ejaculation and difficulty having erections are also things that are associated with prostate cancer. And I kind of mentioned this early on about the effects on your sexual health in reference to prostate cancer, because the nerves that are responsible for causing erection, because of the semen production, all of these things tied into sexual activity as a male. If the prostate is abnormal, the prostate is growing uncontrollably, the prostate's tissue around the area is being damaged, this can affect your sexual health. And I usually spend a little bit of time talking about this, and the main reason is because my thought process is that as a man, these are things that you don't want your sexual health to be affected. You don't think as much about your long-term health especially as a young man, but sexual health is not something you want to be affected. Addressing prostate cancer at a timely fashion and not letting it get to the point where it's growing out of control can be something that can burst sexual health. The more advanced the disease gets, the more often the treatments being given are associated with causing like erectile dysfunction. So, and finally, and this is, certainly worst case scenario, and where if they do end up in this space, then the prostate cancer is actually spread outside of its normal habitat, and it's in a bone, or it's in your lower back, or it's in your hips. It's in a place outside of the prostate, and it's a bone, a common place that you'll see prostate cancer spread to. So the patients are thinking about these things because there possibly is cancer that's in another area that's not the prostate. So looking at prevalence. As you can see, if you're below the age of 40, you essentially going to have a 1 in 10,000 chance of being diagnosed with prostate cancer, as they're looking at, large scale studies to show like how often do patients that are below 40 get diagnosed with prostate cancer. However, once you cross over that 40 years of age threshold, you see that it goes from 1 in 10,000 to 1 in 8 men are diagnosed. So as you might imagine, 40 becomes a very, very important age when it comes to prostate health and getting screening for prostate cancer. When you go to 60 or 69, which is why I referenced my father being 60, then you're at 1 in 14 men are diagnosed. So you're looking at a substantially great jump in the amount of patients that are diagnosed when you change from age 40 to age 60. So that 20 men, you have a substantial increase. And it's something that should definitely be on the radar. All of those symptoms that I talked about should definitely be something that you as an advocate for yourself are looking into and making sure you're paying attention to. And then finally, you know, you look at prostate cancer in general, you see how 65% of the cancers are diagnosed in those men that are above the age of 65. So 65 certainly is where there's a lot of times the key to this is diagnosed. So diagnosed does not mean that the patient's developing prostate cancer cells specifically at 65. A lot of times you're looking at if there's not screening, there may have been prostate cancer that were developing a lot sooner than that. But if the patient is not being regular like they should be, or if the patient is waiting until they have the symptoms that are severe, as I talked about, then they may be diagnosed a lot later than when they actually those formations of cells that are considered to be precancer will eventually develop into prostate cancer. So looking at your diet heavy in red meat and fatty dairy products. I know we as men, or a lot of us, we love our big steaks and, you know, all of our, you know, I can't lie and tell you that I'm not a fan of barbecue, briskets and all types of things of that sort. That's something that, me being from Dallas, that's a big thing from us. We're barbecuing at the drop of a dime, and we love those types of foods. It's important to understand that heavy intake of that is actually associated with developing prostate cancer. So those fatty dairy products, and of course, you know, now you're talking about all your cheeses and your milks and, you know, all of those things. And this is heavy amounts. It's not that you can't drink milk. It's not that you can't drink red meat. The studies show that heavy intake of that is where there's a possible association with developing prostate cancer. What's most important when you're talking about risk factors associated with prostate cancer is definitely family history. So family history is, you know, at the top of your list as far as like what you want to do if you see a patient who has family history, how aggressive you want to be with prostate cancer screening. So first degree relatives, I mentioned this earlier, your father, your brother, or your son. Them having a history of prostate cancer immediately increases the risk by 2. So it doubles your risk if you have a first degree relative who has prostate cancer. And if you change that number from 1 to 2 or more, now you're talking about 4 times the risk. So really, anybody in your family, if you know that they have prostate cancer, especially if they're a father, brother, or son, your antennas should now be up, and you should really be thinking about, let me make sure I'm getting my screening when I'm supposed to get my screening. Let me make sure I'm doing my part to make sure if this does show up in my lifetime with me, that I'm going to address it as early as possible to have the least amount of side effects from the treatment as possible, as well as have the best outcomes in reference to your life being saved and you not having a substantial amount of treatment that you had to go to for a long period of time. And then when you're talking about who has the highest risk, so when you're talking about relatives, and if they're diagnosed, not only are they your relatives, they're diagnosed in an early age, then they have a high risk. Patients who get diagnosed before 65, which remember I said about 65% of prostate cancer are diagnosed before age 65 or after age 65. So the vast majority after that. Anybody who's showing up earlier than that, their family members are at the highest risk. So they not only got prostate cancer, but they got it when they were below the age of 65. And that is like the thing where if I talk to you, you tell me yeah, my father had prostate cancer. And I'm like, okay, when was he diagnosed? If you tell me he's diagnosed at 75 versus a patient who tells me that their father was diagnosed at age 55, that patient whose father is age 55 that was diagnosed, they're at a high risk of developing prostate cancer versus the patient whose father is 75 when they were diagnosed. So these are, and discount the hereditary cancer syndromes that are associated with prostate cancer, because there are most of them, specifically Lynch syndrome is one that shows up, and it can affect women negatively by increasing their risk of developing endometrial cancer, but it also is something that can increase the risk of developing colorectal cancer, which is also a very prevalent cancer in the United States and men in general, as well as African American, being more specific. It's associated with these specific repair genes that are mismatched, meaning there's a abnormality in the way the DNA the formation of the DNA. So in those mismatched repair genes, it's going to cause patients to have Lynch syndrome. So we know these patients have high development all types of cancers, not just prostate. Also, it's something that if you have any kind of history, or of course, like, you have women in your family, you've been involved with their health, or you have breast cancer history in your family, you know that the BRCA1, BRCA2 genes are most commonly associated with breast cancer. However, actually increase your risk of developing prostate cancer also. Men can have a BRCA2 gene mutation just like women can. So while prostate cancer is also associated with it, breast cancer is associated with it, ovarian cancer is with BRCA1 and 2 genes. So, for purposes of our conversation, if you have a woman in your family that actually has a BRCA mutation, your man should also be tested, because that can possibly predispose you, increase your risk of developing prostate cancer if you have a BRCA1 or BRCA2 gene mutation. So ethnicity and nationality. So this is, where, of course, like Dr. Adjewale's study that she's directing, that's on the aggressive prostate cancer study, trying to look at what kind of things we can do and how we can intervene to help American men who are 61% more likely to develop prostate cancer versus Asian males. And also nearly 2.5 times more likely to have prostate cancer. So this in itself is a risk factor. So we talked about age, we talked about family history, we talked about how you eat, we talked about all of these things, the genetic predispositions, BRCA mutations, syndrome. We've talked about all of those things. So on top of that, if any of those things and any of those things fit into the criteria, and in addition to that, going to be an African American male, you see that you do have a substantial risk that you should be mindful of. You should be mindful of, and this is the most common non-skin cancer that you will see. And it keeps saying my internet connection is unstable, so I try to stop when it does that. So back to the other thing with the ethnicity and nationality, compare that to Asian Americans, Hispanic Americans, Indians, all of these men, once again, less likely to develop prostate cancer compared to African American males. One place where prostate cancer is more prevalent is essentially in North America in general. So the country that we live in, the continent that we live on, this place has prostate cancer than other parts of the world. So I attribute it probably to our diets, because I don't know anybody that probably doesn't have some type of in their refrigerator and doesn't love cheese. We love steaks. We love brisket. If you're in Dallas, we're eating all of the ribs. We're eating beef ribs, the dino ribs. We're eating everything here in Texas. So we know that, and that certainly affects the prevalence of prostate cancer. So screening, what should we do? Why should we do it? So on and so forth. So when you're looking at screening, 2 tests that are used to actually possibly identify a patient possibly being at risk of developing prostate cancer, and then verifying that patient has prostate cancer. So the PSA blood test, or the prostate specific antigen, is something that just because it's elevated, it doesn't directly mean that a patient has prostate cancer. It's actually elevated in a host of different scenarios. So it alone cannot diagnose a patient with prostate cancer. there needs to be a digital rectal exam, which is a clinical exam performed by typically a urologist, or it could be a internal medicine or a primary care physician, or of course an oncologist. This digital rectal exam is the other thing to palpate and adjust. It really is addressing the size. It's trying to see the consistency of how the prostate feels and the size of the prostate to see if it's enlarged. So the PSA blood test being elevated and having an abnormal digital rectal exam, which would show that the firmness of the prostate is consistent with possibly being cancerous, and then also the size of the prostate being enlarged, are really your two avenues to get you to the point where further information is going to be gathered to ensure and rule out you having prostate cancer. The prostate specific antigen, or the PSA test, is also frequently elevated in patients who have prostatitis, which I'll talk a little bit about this at the end, as well as BPH, which is benign prostatic hyperplasia. These are two conditions that develop in patients, and it causes them to have a lot of the same symptoms that you really see with patients who have prostate cancer. However, there's not a cancerous lesion there. So the BPH is just the abnormal growth and enlargement of the prostate, but it's not cancerous, meaning it's going to go outside of the prostate and cells get on your bone, and cells get in your liver, or cells get on your lungs. With prostatitis, usually going to be possibly cause infections, can sometimes cause prostatitis, which is an inflammation of the prostate gland. Inflammation of the prostate gland is going to cause some of the same symptoms that you see with patients who have prostate cancer. So it's, once again, when these things are present, the elevation in PSA, abnormal digital rectal exam, which is palpating the prostate gland, when these things are abnormal, we are still going to look at some other things to make sure we rule out a patient actually having prostate cancer before we just diagnose them. But these two tests are, when we're talking about screening and you as a patient understanding what to happen with screening, what you should expect, one of them would be a test, and one of them would be a clinical exam that's performed by a health professional. Typically, like I say, usually your PCP or urologist are going to be probably the first digital rectal exam that a prostate cancer patient is going to receive. Now, as far as the American Cancer Society and what do they recommend, they typically recommend both tests be done annually, beginning at age 50. And this is in a patient who's at normal risk. So of normal risk. I am not of normal risk. So I'm considered to be in a high risk category. So in 6 years or 5.5 years, I will need to start getting prostate specific antigen blood tests on top of my labs that I get when I get my checkups, as well as get a digital rectal exam. So I need to start at 45. Now, if you were an individual who had one of those first relatives that were affected early on, and no, it's probably not necessarily conducive, doing question and answer, but hopefully, like when I get done, we can, have some conversations if you guys have questions. But if you remember, when I affected at an early age, that means prior to age 65. 65 is a magic number. Your father, your brother, your son was dosed at before age 65. It would be recommended you begin testing for a PSA blood test as well as a DRE or digital rectal at age 40. This slide and this information slide is the most important information that I've essentially presented to you today. If you're doing anything today, if we can affect you in any way, understand when it is recommended that you yourself as an individual be tested and screened for prostate cancer. So we'll do it one more time. The average risk patients should be screened at age 50, starting at age 50. High risk, that once again would include African-American men or men with strong family history, meaning they can have a first-degree relative, but if first-degree relative was diagnosed before the age of 65, we not only want to look at them being screened at age 40, go all the way down to age 40 when they have these multiple first-degree relatives being diagnosed prior to the age of 65. So PSA, DRE, that's what needs to first. What happens after that, if you are a patient, and let's say you had this abnormal DRE and you had an elevation in reference to your PSA levels, that's when a biopsy needs to be done, which is actually a collection with a needle of cells from your actual prostate. Of course, like if you did have to go through this and you did a biopsy of the prostate, it will be local anesthesia. It's not, we're not 10,000 BC where you're doing everything with no pain medication not being. However, that tissue sample does need to be analyzed. It does need to be rapidly analyzed by a pathologist to make sure that the cells that they're seeing are abnormal, are actually cancerous, because it could certainly be hyperplasia, benign prostatic hyperplasia, which is BPH. That means that your prostate is enlarged, but the cells are not cancerous. Okay. So when you talk about prostate cancer, I always like to present this slide, and the reason why is because at least is a silver lining if an individual was diagnosed with prostate cancer, as long as we can diagnose you at an early stage. We do expect high cure rates with prostate cancer. We do expect high cure rates, meaning patients have, after they're treated for their prostate cancer, they have long, extended periods of time of having the disease-free interval. Okay, so catching it early, patients are usually going to remain disease-free after they get their treatment for the remainder of their lives. Over 90% of prostate cancers are usually detected when it's local or regional. Local or regional is the symptoms I described early on when we went over the symptoms of prostate cancer. So all of those early symptoms that are really focused on how your urine looks and what your urine is doing, and those types of things. When we start talking about you having back pain, you having pain in your leg, or you having trouble breathing, those are things that are more associated with severe cases of prostate cancer. So definitely cure rate being very high. You see the disease survival for men who are diagnosed when they have local or regional disease is actually almost 100% at 5 years. 5 years is a magic number for us in the field of cancer, because if we can keep a patient cancer-free for 5 years, we typically consider them to be cured. So that's why 5 years is mentioned there, in the nearly 100% of men that are diagnosed at those stages having a very high cure rate. We're just, briefly talking about surgery, which will give us this, surgery and some of the other things to give us a little bit of time at the end to possibly have conversations, or you be able to ask me questions. You can have a partial prostatectomy, or open prostatectomy, or radical prostatectomy. And really all that means is that if there's a smaller amount of the prostate gland that is affected by the prostate cancer, the less of the prostate you have to remove. Typically, if you are going to move, or you have the more severe disease, you're going to have to do the radical prostatectomy. So the radical prostatectomy, of course, removing all of the seminal vesicles, which is something that's actually attached regionally to the prostate gland, as well as the whole gland of the prostate. So that's worst case scenario when you think about what happens with surgery. Radiation therapy, which is a very important part of patients who get treatment for prostate cancer, is actually going to be targeted specifically in the area where the prostate cancer cells are located. And sometimes radiation can replace surgery. So instead of removing your prostate gland, and the reason why some men don't want their prostate gland removed is because if you interrupt any of those nerves, that can possibly cause the erectile dysfunction that we were talking about. So radiation therapy is sometimes what patients will opt for when they're given all of the side effects the surgeon on what needs to happen if they get a prostatectomy. So you have an option for prostatectomy or doing radiation therapy, depending on what your clinical stage is. Now, as you get more advanced, it starts being a space to where you need to get the radiation and the surgery possibly. So it's all about how advanced you are when you're diagnosed. Certainly, surgery and radiation are mainstays in what happens to a patient once they develop prostate cancer. And then finally is the hormone therapy. So we haven't talked about this as much. However, this is the time to mention that prostate cancer is a disease state that's the prostate, and actually the enlargement and the abnormal growth is driven by testosterone. That's it's a theory that it's a possibility that African-American men produce and make more testosterone, which then in turn causes us to have more exposure of our prostate gland testosterone. And that could be what increases our incidence when you compare us to our Caucasian, Asian, American, Indian, Hispanic counterparts in developing prostate cancer. Okay, so androgen deprivation therapy actually is directly related to blocking your body's ability to make testosterone, as well as blocking any testosterone that is made from acting on the prostate gland. So that's what hormone therapy is. And so when you think about what treatments need to be had and what needs to happen, the actual testosterone block is the most important thing to do, especially if the prostate is still intact and can be stimulated from growth. And then just briefly about chemotherapies. TAC is just a family of chemotherapies that's used with steroids, and then platinums are another family of therapies that's used to possibly treat prostate cancer. But this is, of course, more in the more severe cases. The things that a patient should expect, unless they're in the very late stages of prostate cancer, is actually that surgery we talked about, radiation therapy, different forms of radiation therapy, and therapy that targets the production and the activity of testosterone. So side effects, if you do have the surgery, okay, and it would be, and I alluded to this, is the surgery does remove the prostate, which has a lot of nerves and is very, very bladder, fecal incontinence and urinary incontinence, which means that you wouldn't control your urine or your stools, is something that can possibly be a side effect. Not most nerve sparing surgeries, and that's what I was talking about with the nerve sparing attempt, essentially to avoid the problem with the sexual dysfunction and keep those nerves intact. Patient can still have an erection like normal they had their prostate. So that's always another conversation. And then sperm production. So sperm production, of course, becomes very important if you have that are interested in still having children. Okay, so that's a fertility conversation is had typically with all of the patients that are either in relationship to where their kids are still on the horizon, or it's a plan. If there's going to be a surgery, like the fact that there needs to be you need to freeze your sperm and do artificial insemination, all of those things. A conversation is had about that because the sperm production is pretty if there's a prostatectomy performed. So prostatitis and BPH, or benign prostatic hyperplasia. It's a little bit earlier, but very important to differentiate these two with prostate cancer. These two are both not associated with invasive or cells that are going to come outside of your prostate and affect other parts of your body. These two symptoms, or these two syndromes, are both associated with actually elevations in your PSA. So that's another thing that understand, is that a patient could have high PSA levels or have elevated PSA levels and not have prostate cancer. Sometimes they can be treated with, like I say, antibiotics is a common thing. When you see prostatitis, there's recommendations on antibiotics to give. Some men can have chronic infections and prostatitis, and it doesn't have to be when you're 65. You can have prostatitis when you're 45. So it's not necessarily age related. Okay, so those are two things that have on your radar as well that are different from prostate cancer, but have very similar symptoms, and even some of the labs look a little bit similar as well. So prevention of prostate cancer. What things can you do to help prevent prostate cancer? Increasing your fruits, increasing the vegetables that you intake, having lower amounts of fat in your diet, decreasing the amount of brisket sandwiches that you eat. So I know I just try to eat brisket like once a month, or maybe twice a month, depends if you count leftovers. But cholesterol being elevated, also something that, try to keep your cholesterol down. It's also something that, of course, associated with eating those fatty foods. So kind of go hand in hand. Smoking has also been associated with prostate cancer cells growing faster than patients who didn't smoke. So that's something to definitely be mindful of. Exercising on a regular basis, keeping your stress levels down, and finally get enough rest. These are things that we as human beings need to, all three of those things are extremely important. Being able to exercise on a regular basis, doesn't have to be daily, multiple times a week, making sure you're getting enough rest, and reducing the stress level. Seems like simple things, and seems like maybe it doesn't have as much to do with developing cancer, but obesity is associated with an increased risk of cancer, not just prostate cancer. Increase, like when you're not sleeping, you're getting rest, and you have high levels of stress. Stress actually causes you release chemicals in your body endogenously that can cause cancer. So high levels of stress cause you yourself to release all of these chemicals that negatively affect your cells and can develop into cancer. So keeping your stress level down, keeping those toxic people out of your life, those, whoever those people may be, keeping them out of your life can actually help with your overall health. So as we round out to the end, which we still look at, we have a little time for questions. Genetic counseling. So genetic counseling is something like I talked about syndrome, and I talked about the BRCA1 and the BRCA2 mutation. You can actually a genetic counselor referral, typically from your PCP or your urologist, if you have the cancer in your family, identify if you actually do have these mutations that may constantly increase your risk of developing prostate cancer. So it's certainly worth the conversation. It's worth the time to go through this process to find out if you are a patient that's at increased risk, and it might be more beneficial for you to start getting your prostate cancer screenings early. Patients who in group 1 or, a lot of my college students that I do, they're in group 1. Patients in group 2, these patients are certainly patients who, you're really wanting to watch these patients. They've had a cancer diagnosis, and may have not only had a cancer diagnosis, maybe it's not prostate, but they know that they're possibly at high risk of developing. Sometimes patients can develop one cancer and then on top of that develop another cancer. So they already have this cancer that's occurred. Then being in group 2, which is the group that definitely you'd want to recommend the counseling for, is certainly appropriate. And all of the information that I pulled together and it's come from multiple cancer centers. Dr. Adjuole, who introduced me earlier, practices at Houston Methodist Cancer Center as a clinical pharmacy specialist. I was trained at MD Anderson Cancer Center, following pharmacy school. After completing my oncology fellowship, I came over and transitioned into UT Memorial Hermann Cancer Center, where I practice at currently. Prostate Cancer Foundation was also helpful in me gathering and putting this information together all today. And finally, Texas Oncology. Some of the information was drawn from some references from Texas Oncology. So I thank you all for all your attention today, and hopefully you learned some things. Some things are helpful for you and even as women, because this presentation can be beneficial for women, because honestly, y'all are the ones that care of most of us men when it comes to health, for sure. So you as a woman knowing all this information helps your husband, your significant other, so on and so forth. So I thank y'all for y'all's attention today. I'd be happy to field some questions for the last part of the segment before you guys go back to the health fair.
I'm verifying if there's any questions over at the Hardy Center.
No problem.
Hi, good afternoon. I just had a quick question. Earlier you talked, can you hear me?
I can't. Yeah, I can hear you.
Okay, earlier you talked about advocating for your health. Most of us, a lot of us work in healthcare, so we know how to do that. But for people that don't, sometimes it can be very intimidating. I have my best friend, Iman, she passed away from colon cancer at the age of 35 because doctors wouldn't listen to her. And she was a medical student prior to, but she knew the importance of going to the doctor when she wasn't feeling well. And she went to doctor after doctor after doctor after doctor. And they kept giving her pain medication, or they said, oh, you have to have gas. Well, finally, she found a really amazing doctor in DC, and he sent her to have a colonoscopy and discovered she had colon cancer, but by then it had spread. She passed away. So what are some ways that people can advocate for their health when they feel intimidated by providers? Should they continue to just go to different doctors until they say yes? Or are there other avenues that they can advocate?
Sure. Great question. Great statement. And what I'll say is that, you know, I'm sorry to hear about your friend, but the reason that I'm here, the reason that as well as the reason that our whole team is here is the thought process is that we'll come to the community and a patient will hear what I'm saying or hear what she's saying. And even if they're reaching out directly to us, we have a direct line to a healthcare system that we know will get the patient the appropriate help that may be underrepresented or not being heard, so on and so forth. I have multiple students, I have multiple patients, I have multiple individuals in my family friends that have reached out to me directly to obtain not only information, but possible treatment recommendations about what's going on with a family member that's having a problem. And once we distribute this information and we get all of this out here, the thought process is that you would take it back to your family and the other individuals would take it back to their families, and we can impact the health of the community in that way. Because it's unfortunately, it's a very sad story to hear patients who frequently complain about symptoms that I've talked about today, or symptoms of colon cancer, symptoms of breast cancer, and essentially not being heard appropriately because maybe the individual that saw them has 40 other patients to see, and they're missing the fact that they have, you know, hallmark symptoms of certain disease states. So our point here, and the reason why we're here, is to hopefully be a liaison between the community to bring them, whether it be the TSU, whether it be the Methodist, whether it be Morton Hermann, whether it be the MD Anderson, wherever, to make sure that we're going to get them the best health and care that we can. That's not always from the place where they received their health initially. It may be from a different place, a fresh set of eyes. And it could be, life could be on the line in this situation. So it's worth the time, it's worth the effort to reach out to someone if you feel like you're having these frequent symptoms that aren't being addressed with whatever the treatment is being recommended here.
Okay, Dr. Hunter, it looks like everyone over here is good. No further questions.
Thank y'all at the Hardy Center for y'all's attention, and of course, thank the attendees that joined online as well.
Hi, everyone. Thank you so much, Dr. Hunter. I'm going to go ahead and share my screen now. Let me see how it goes. Okay. All right, everyone. Thank you all so much for joining us. Right now, we're going to move on to bingo. Again, hello, I'm Evelyn. I'm the project coordinator here at the Community Engagement Corps. Once again, I'd like to thank the Hardy Senior Center, Ms. Ashe, Ms. Chara, and Mr. Thomas for helping us out with our event. I'm going to go ahead and put a chat in the link. Said that wrong. A link in the chat box, so you all can join us and play bingo. Let me see. Give me 1 second. There it goes. Where's my chat box? Okay. Okay, if you all click the link in the chat box, you all should be able to join our bingo game. And for our Hardy Senior Center attendees, you all should have gotten a little bingo card, and you all can just scratch with the pen and see if you win. And if you win, just put it in the chat box, just say bingo, and so we can pause the game and restart. We're probably going to do like 2 rounds of this. Okay. All right. Dr. Hunter, it's the first word is symptomatic. Would you like to say anything on our first word?
Oh, you said a patient is symptomatic?
Yes, that's the first one.
Oh, it is. Let me see. I'm putting I'm trying to get the link. I'm trying to or do you want me to play?
I mean, you can if you like. Yeah, I'm calling the game. So the first word is symptomatic. So once you click the link, your bingo card should come up. You're just going to click on the word I'm calling out. So the first word is symptomatic.
Okay. So you want me to give them some symptoms that
Yeah.
they may have?
Is there anything like maybe a little definition, or if anyone has a question on the meaning of it or any questions on it, let us know.
Sure. Just
Let me
Just
see. I don't know.
remember, you know,
I'm trying to see if there's anyone. No questions yet in my chat box. Okay.
okay.
All righty, then I can move on to the next word. Let's see. Next call. Clinical trial. Clinical trial is your second word. Don't forget that if you get a bingo, just let us know. Put it in the chat box, bingo, so we can start over. And if you do win, just put your email address in the chat box so I can reach out to you later for a little prize. And if you are in the Hardy Center, just let some of our volunteers know that if you did get bingo, so that we can give you your prize. Third word is bladder. Bladder. Okay. Fourth word is diet. Again, if anyone has any questions on any of these words, or Dr. Hunter, feel free to jump in if something comes up in your mind, let us know. So we can.
Stay away from all of that brisket.
That's hard. We live in Texas, but we're trying.
Yep.
We can do this.
I did. I'm not gonna lie. I smoked brisket last week. I'm not gonna for Juneteenth. So I'm not gonna say I'm not eating brisket. I eat brisket 1 to 2 days a week. I didn't say I didn't eat it, you know. So I'm putting it out there.
I agree. Let's see. Next word, our fifth word is diagnose. Diagnose.
Remember, 40 and above. Men who are 40 and above, like they have a more frequent incidence of being diagnosed with prostate cancer. So, and then if they're above the age of 60, it's even in higher risk. And then when our patients that are above the age of 65% of men who are diagnosed with prostate cancer are above the age of 65.
Next word, our sixth word, weight. Weight.
We got a winner. Can you guys hear me? We got
Yay, we have a winner. Yay, Hardy Center. Okay, great. Let me reset this.
He checked that. He checked that word. Okay, we got one winner over here.
Oh, so there's 2 winners at the Hardy Center then.
Yeah.
Okay, great. Great. Okay, so there's 2 winners so far. So we'll do one more round of our bingo, and then we can finish off the rest then, okay? Let's see, start game. Okay, first word of our second round is inflammation. Oh, I think we have another bingo at the Hardy Center. I think another one just popped up from this first game. I believe so. Inflammation. Okay. They got their prize. Oh, okay. I guess I can continue it for our online attendees. Second word is a diet. Diet.
Fourth winner.
Oh,
I think the Hardy Center took this one.
yeah, they're on fire today over here. Okay. Yeah, I see them. Yeah, okay. Symptomatic is our third word for our online attendees. Symptomatic. The Hardy Center, I see that it's pretty over. they took it on the first try. Okay. Fourth word is bladder. Bladder. Fifth word is benign. Benign. Okay. Sixth word is prostate gland. Prostate gland. Okay. Seventh word is treatment. Treatment. Okay, next call. Eighth word is counseling. Counseling. Ninth word is stress.
Bingo again.
Bingo again.
Yeah.
Okay.
They got too many bingos.
Yeah, they have a lot going on over there.
We got
Great.
one bingo like that. We got one bingo over here too.
Yay, Hardy Center. So all of our bingo winners were from the Hardy Center. Okay, I'm
Well,
gonna move on.
we got one. We got one from the. There's one in the chat.
Is
Yep.
Yay, we got one. Okay. If you could just put your email. I see it. Yay, we have one. Yay, one virtual. Perfect. If you could just put in your email address into the chat box, I'll reach out to you after the seminar. Perfect. Got your email. Okay. All right then. So we did have several bingo winners. Hope you all enjoyed that. It's just a little fun game that we do at the end of our seminar, and Dr. Hunter's always so graceful to join us and explain any definitions or if you have any questions on any of those words. Okay, just last minute announcements. If you all could please fill out our survey. I am going to put it again in the chat box. If you all fill out our survey, just to let us know how we're doing, how we can better our program, and if you have any specific topics that you would like to hear from us. Okay. I would also like to take the time to invite you all to our upcoming seminar. It's going to be on July 2022. Just save the date. It's going to be on healthy behaviors in adolescents. I'll be sending you all an email, all of our attendees following up, sending any calendar invites, or if you guys want to reach out to me, you always are more than welcome to. I'm going to follow up with an email sending you all of the information with our upcoming seminar for next month. And lastly, again, thank you so much to the Hardy Center. Again, Ms. Ashe, Ms. Shara, and Mr. Thomas for helping us out and set up this beautiful event for everybody. Thank you so much for all of our vendors. And special thank you to Dr. Hunter. Thank you so much for presenting with us. We hope you all enjoy it. And don't forget to join us on social media at CEC Texas Southern U. We are on Facebook, Instagram, Twitter, LinkedIn, and YouTube. If you have any questions, put them in the chat box and I'll reach out to you guys. Thank you. You all have a great day.
You as well. Thank you.
Thanks, Dr. Hunter.